My topic is to talk about getting basics right and improving outcomes for people with diabetes. You must be seeing that the introductory slide itself is very busy. I have been highlighting several societies, several guidelines, but then there are multiple recommendations, but we need to get the basics right. By saying that, what I mean to say is that you need to pick up things at the earliest and do the right thing at the earliest. Why should we do that? Because type 2 diabetes has impact on longevity. This was a wonderful article in Circulation 2019. You can see from the graph on your right, age at diagnosis defines the life years lost. Less than 20 years, 12 years life is lost. At the age of 45 years, if you're diagnosed as type 2 diabetes, 6 years are lost. And if you are diagnosed at the age of 65 years, still 2 life years are lost. This is followed by another article in NEJM which says at the age of around 50 years, you lose around 6 years of life. And if you talk about risk factors, more than 50% of people of type 2 diabetes have one or other risk factors like dyslipidemia, obesity, age more than equal to 55, hypertension, and smoker. Some are non-modifiable, especially the age factor, and most of them are modifiable. So we have to be miser in our expectation from anti-diabetic drugs. It should not only reduce the sugar, but should also give us relief as far as other risk factors are concerned. The complications of diabetes are known to us since ages. We have been taught by our teachers, seniors. There are microvascular complications, there are macrovascular complications. We have atherosclerosis, vascular remodeling, arterial fibrosis, all these things coming into the picture when we talk about the pathogenesis of vascular complications. So what about hyperglycemia per se contributing to macrovascular risk? This is a wonderful nurses' health study, a 20-year follow-up of more than 1 lakh patients. And what you can find is this gives rise to the ticking clock hypothesis, which says the clock for macrovascular disorder or cardiovascular disorder starts ticking much before the diagnosis of diabetes, and the relative risk of MI or stroke goes up by 5 times if you have diabetes at the baseline. And not only that, this was another article in Lancet 2010, which has taken the data of around 7 lakh patients, the emerging risk factor collaboration, and you can see all these parameters, the coronary heart disease, cerebral vascular disease, and other vascular events, all of them are actually going up by 2 times when you have diabetes. If you talk about some other registers like Swedish National Diabetes Register, again, a staggering 4.5 lakh patients, and look at all the 3 parameters, death from cardiovascular disease, death from coronary heart disease, hospitalization for cardiovascular disease, all of them, they go up 2 times. And the Asian Indian phenotype, we all have been talking a lot. Then this is the retrospective analysis of J Dreams, which was done on Japanese people. And they have tried to look at the number of permutation and combination that are feasible when a person is having type 2 diabetes, especially in cases of Asians. And you can see, I'm not going to read out all those for you, but there is a number of permutation and combination which can come to the fore. And look at the percentages, the obesity, type 2 diabetes, dyslipidemia, CKD, and there are bidirectional association between most of these conditions. And multiple comorbidities also dodge the Indian phenotypes. They have greater degree of central body obesity, higher insulin resistance, and characteristic dyslipidemia. And recent few studies have come up which have shown that the beta cell dysfunction sets in quite early in Indian subjects. And when you have these comorbidities in combination like hypertension and abdominal obesity, you are at a 2-fold risk of cardiovascular and a 40 to 70% increased risk of renal complications. So therefore, now that we know what are the things that have been dodging the Indian type 2 diabetic patients or the patients having diabetes, we need to screen patients appropriately to detect complications early and to prevent further degradation. We know, we have been taught by our seniors. I am sandwiched by 2 wonderful speakers, Vijay sir and Benny sir. Benny ma'am. Yes, we know that we need to screen, but then look at the International Diabetes Management Practical Study, which says that for cardiovascular disease, 20% of type 1 and 16% of type 2 diabetes have never received screening. For retinopathy, 9.5% of type 1 and 20.5% of type 2 diabetes have never received screening. And for microalbuminuria, 23.2% of type 1 and 36% of type 2. And similarly for neuropathy, 18% of type 1 and 26% of type 2 diabetes have never received any screening modalities. If you talk about Indian data, probably the numbers would again swell up to unimaginable numbers. And these are the screening recommendations. As I've already started by stating that We need to pick up things at the right time. And how do we pick up? These are the screening mechanisms. So retinopathy, type 2 diabetes at the time of diagnosis, type 1 diabetes within 5 years of diagnosis. And when exactly do we repeat it? If in one or two examinations you find there is no retinopathy, you can do it once in 1 to 2 years. If there is presence of due to progressing retinopathy or there is sight threatening, you have to measure it more frequently. If there is some sort of retinopathy at the outset itself, you have to measure it annually. The peripheral neuropathy, you should be screening at the time of diagnosis and then onwards annually. And foot, which bears the brunt of the disease, has to be screened at each and every visit. And diabetic nephropathy, the creatinine and EGFR at the time of diagnosis, and the albumin creatinine ratio, unfortunately, is being missed by many of us. Type 1 diabetes, it should be done in people having duration more than 5 years. Type 2 diabetes at the time of diagnosis. And if it is normal, measure it annually. If it is high, within subsequent 3 to 6 months, do it 2 to 3 times. If more than 2 values are more than 30, you have to treat it. Otherwise, rescreen annually. What about the cardiovascular disease screening? In asymptomatic patients, it is a big no. It should be considered for patients having coronary artery disease in presence of any of the following, like atypical cardiac symptoms, signs or symptoms of associated vascular disease, including carotid bruit, transient ischemic attacks, stroke, claudication, or peripheral arterial disease, or if there is any electrocardiographic ECG abnormalities. What about children and adolescents? The slide again looks busy, but I'm going to sum it up by stating that you should be screening the presence of thyroid disease, celiac disease, hypertension at each visit, and dyslipidemia soon after diagnosis. But when you talk about nephropathy, retinopathy, and neuropathy, it should be checked at puberty or more than 10 to 11 years old, whichever is earlier, and diabetes duration of 5 years for nephropathy and neuropathy and 3 to 5 years for retinopathy. We should not be missing the persons who are at extreme need of our care, the older adults. We should be doing an assessment of medical, psychological, and functional and social domains, and we should be able to judge their ability to self-manage. And what about the quality of life? And neurocognitive function always takes a backseat. But the ADA states screening for early detection of mild cognitive impairment of dementia should be performed for adults 65 years of age or older at the initial visit and annually as appropriate. Now that we picked up the things, we should be all proceeding the treatment. What should be done? After that wonderful talk by Vijay sir about the beta cell preservation, my talk would be easy, but we all know that this is patient-centered approach. We should gauge the patient preferred level of involvement, and there should be a shared decision making. We have come across conferences on mind-body medicine. How do we communicate with compassion and empathy to the patient? And what is the impact of these 3 parameters, the blood sugar, blood pressure, and lipids? We all know for microvascular complications, there is a linear relationship between blood sugar and the complications. But whereas the macrovascular complications, yes, the blood sugar is important. But apart from that, the STENO2 study clearly tells us that the blood pressure, blood lipids, and other risk factors are also supposed to be taken care of. This one is in Lancet 2009, which says the impact of each of these interventions. The systolic blood pressure reduction, the LDL cholesterol reduction, and A1C reduction, their impact, and the best one is the systolic blood pressure. I would quote one just interesting question from Professor Bhansali during our endocrine residency days. Hyperglycemia is predominantly contributing to peripheral arterial disease. Hypertension is contributing to predominantly cerebrovascular disease, and dyslipidemia is predominantly contributing to cardiovascular disease. But for complete control, you need to have all these under check. We know A, B, C goal, we have been taught several times, but to improve the outcomes, these are the parameters, but only 18% of people achieve those A1C goals, A1C of less than 7%. This slide, we must have seen n number of times, but again, it reiterates the fact that glycemic control is very, very important as far as microvascular disorder is concerned. And some of the long-term studies like the UK PDS and the EDIC study have also told us about its importance as far as cardiovascular disease reduction is concerned. And again, just to tell that glycemic control is equally important for reduction of microvascular disease states, risk of CV death, non-fatal MI, non-fatal ischemic stroke. You can see the parameters which are important at the A1C, the LDL cholesterol, and the systolic blood pressure. So what about the glycemic targets? Non-pregnant adults less than 7%. And nowadays we have this time in range, which should be more than 70% of the time the blood sugar has to be within the range. If a person is younger, has long life expectancy and has no cardiovascular disease, he can be given a more stringent A1C target without any hypoglycemia. On the contrary, an elderly person, short life expectancy and conditions predisposing him to have more of hypoglycemia, goal of up to less than 8% is also appropriate. Anti-hyperglycemic therapy, the lifestyle at each and every stage. Recently, I came across a Cochrane meta-analysis which says that the lifestyle intervention at any stage does give rise to benefit as far as metabolic and your other health is concerned. Oral agent, non-insulin injectables, we all know, but then, and the insulin is also important. And as far as beta cell preservation is concerned, we learned from Vijay sir about the incretin-based therapies, the short-term insulin therapy, DPP4 inhibitors, and also SGLT2 inhibitors. So therefore, the ADI 2022 clearly tells us that yes, metformin is the first line of therapy, but if you have any of the high-risk conditions like ASCVD or high-risk or heart failure or CKD, you have to pick these wonder molecules. Those are the SGLT2 inhibitors and the glutides, which are the GLP-1 receptor agonists. And we have few more in the kitty, like the oral semaglutide, which is launched recently, and the tirzepatide, which is the quincritin analog, which got approved very recently. And there is also this trial Amplitude O, which basically tried efpiglenatide, which is a GLP-1 receptor agonist in combination with SGLT2 inhibitor, and this combination was doing actually wonders. Very importantly, we should not be missing the quality of life issue, because care with compassion and language matters, as I've already stated. More the patient is satisfied, the greater is the medication adherence and the better quality of life, because it is a lifelong therapy. So we need to take the patient into confidence and increase his confidence on the treatment that we're giving. And there are some QL scores, the DAWN score, the SF12 score, which can be used, and lesser number of medicine is always welcome. And the last point, which is the sixth point, I derived it from one of the studies by Dr. Manas Barua from Assam, who stated that insulin along with OHA gives rise to better compliance with, as far as diet is concerned, and enhanced quality of life as far as, because of their better diabetes related knowledge. What about the blood pressure? A number of mechanisms are interlinked. We are repeatedly asked during our student days how it can be co-associated. There is sympathetic overactivity, the RAS activation, kidney sodium retention, vascular and inflammatory mechanisms. A number of, when these two conditions coexist, you have a number of mechanisms in place which can push the patient towards more of macro and microvascular disease. And this study, again, we have been seeing number of times, NEJM 2005, diabetes and hypertension versus diabetes, there is a significant increase of coronary heart disease, stroke, retinopathy, nephropathy, neuropathy, and mortality. And on top of that, we have also studies which tell us that with each 10 millimeter reduction of systolic blood pressure, all these parameters go down significantly from 9% to 27%. So what about the hypertension in type 2 diabetes? More than equal to 140/90. Whenever a patient comes to you, the blood pressure should be confirmed with multiple readings, including measurements on a separate day. And all hypertensive patients should monitor their blood pressure at home. How do we treat? More than 140/90 and less than 160/100. If there is albuminuria or coronary artery disease, you have to include ACE inhibitor or ARB. Other than that, you have any of the drugs like CCB, diuretic, ARB, and ACE. When the blood pressure initial is more than 160/100, you have to think of the combination therapy. Of course, one among them should be ACE inhibitor or ARB if there is presence of albuminuria or coronary artery disease. Lastly, the cholesterol parameter, the Indian dyslipidemia, again, we have been talking about a lot. High presence of high degree of low HDL, high triglyceride, small dense LDL goes up, females outnumbering males as far as the prevalence of dyslipidemia is concerned. And this article is tried to change the way we look at it. We should not be looking at the fasting lipid values in majority of the cases. So you can go for the non-fasting lipid values at the outset itself. And lipids, as far as lipid is concerned, below 40 years, it should be done at the initial medical evaluation and every 5 years, because above 40, we know that the guidelines tell us that moderate intensity statin has to be given anyhow. And once the statin is initiated or any other lipid lowering therapy is initiated, 4 to 12 weeks after initiation or change in dose and annually thereafter has to be done. LDL cholesterol, the LAI goals, very high risk, less than 50, high risk, less than 70, moderate is less than 100, and low risk less than 100. Non-HDL cholesterol is something which is again very, very important. These are indicated by two different programs. First of all, the NCP-ATP3 says that non-HDL cholesterol is a secondary target with a goal of 30 milligram higher than the identified LDL. But LAI, the Lipid Association of India, says the non-HDL cholesterol is a co-primary target, and it asks us to achieve the LDL cholesterol target first. If TG is still above 200 milligram, calculate the non-HDL. If above goal, add a non-statin drug to achieve the non-HDL cholesterol goal. And not only that, we have to look at the other risk factors. The smoking, we know the retinopathy, the microalbuminuria, macroalbuminuria, all of them, they go up as per this Eurodive IgGM complication study. And yes, the smoking is associated with 70% increased risk of diabetic neuropathy. Alcohol again is very much significantly related to microvascular damage, and 33% excess death can be caused due to alcohol intake. It can give rise to fluctuation in blood sugars. It can enhance the complication. It can also induce a state of acidosis. And look at the impact of smoking on the diabetes complication. Number of those: total mortality, cardiovascular mortality, cardiovascular disease, coronary heart disease, stroke, PAD, and heart failure. Lastly, infective disorders are also to be looked at carefully, because these are the days when we were talking a lot about corona and diabetes. So we have to prevent these disorders like pneumococcal vaccination, influenza, tetanus, diphtheria. This is the article which was published in IJM 2012 that I've quoted. But then the pneumococcal flu, these are the basic ones which we all should be trying to inculcate in our day-to-day practice to a good complication-free life. So to summarize, predominantly the vascular complications are to be tackled. The blood pressure, the blood sugar, the lipids, and other risk factors like smoking, the alcohol have to be taken care of. And apart from that, periodic screening for all these complications as per the existing guidelines should be done, so that these can be picked up early, and there are effective interventions which can actually help us get them back to total normalcy. And we also need to be alert for emerging risk factors like anemia is there for anemia is a risk factor for diabetic nephropathy. Family history again is a very strong risk factor for diabetic nephropathy. So all these factors have to be taken into consideration when we try to treat the patient holistically. Thank you all for the patient listening. Over to the chairpersons.